Our next rhythm is an atrial flutter, an ectopic rhythm that is caused by rapidly firing circuits in the atria that are depolarizing at a rate greater than 250 beats per minute. The AV node is stimulated by this huge number of electrical impulses, but it only transmits some of the impulses to the ventricles, and even then may only do so in varying ratios. Remember that in a healthy heart, this is the AV node's natural way to protect the ventricles from these rapid atrial impulses. We identify a patient with atrial flutter and a ventricular response rate greater than 100 as having an uncontrolled ventricular rate. Likewise, a patient with a ventricular response rate of less than 100 is considered to have a controlled ventricular rate. This is a very important distinction and should be measured carefully. The P waves produced by this rapid depolarization from the atria are going so fast that they look like flutter waves or F waves and have a sawtooth appearance. Let's examine the ECG characteristics for atrial flutter. Rate. Atrial rate is between 250 and 400 beats per minute. Ventricular rate, if controlled, it is less than 100. If uncontrolled, it is greater than 100. Rhythm. Ventricular rate can be either regular or irregular. It is important to note that atrial flutter can have variable ventricular response that will make the ventricular rhythm look irregular. P waves. Normal P waves are absent and are replaced by the pronounced sawtooth or F waves. PR interval, not measurable. QRS, 0.04 to 0.10 seconds. Some of the causes for atrial flutter are the same as those PACs, including alcohol, cigarettes, anxiety, fatigue, and some medications. Other possible causes include coronary or valvular heart disease or electrolyte imbalances. However, this abnormal rhythm is much more likely to be a result of an underlying pathology such as CAD or ischemia, valvular disorders, pulmonary embolism, COPD, or sometimes even a digoxin or quinidine toxicity. It is not also unusual to see atrial flutter in post-op patients with a coronary artery bypass graft. So how does the ventricular rate affect the patient with atrial flutter? As with any rapid ventricular rate, patients with an uncontrolled rate can experience decreased ventricular filling, which can lead to decreased cardiac output. This, of course, places the patient at greater risk for heart complications. The first step in treating this condition is to, as always, thoroughly assess the patient. The next step is to control the ventricular rate. If it's an uncontrolled ventricular response, a rate greater than 100 beats per minute, you must get it under control or slow the ventricular rate. This can be accomplished through the use of drugs such as calcium channel blockers, beta blockers, or digoxin. If the patient's uncontrolled ventricular response remains unstable, more aggressive intervention is required. The most effective option is cardioversion, which delivers a programmed shock just off the highest or deepest part of the QRS complex, or R wave. This provides enough shock to the heart to get it back in line. Usually, a 50 joule jolt is recommended, although as little as 25 joules may be enough to convert the rhythm. Depending on the situation, as many as 100 joules may be recommended because the procedure is nearly always successful at that level. Cardioversion is serious business and requires a physician's order and a physician at the bedside. There must always be a respiratory therapist present in case the patient loses his or her airway as the result of the treatment. Even though the circumstances may be frantic at this point, don't forget your responsibility to be a strong patient advocate and encourage the physician to prescribe a sedative for the procedure. Because even if it is administered at the lowest levels, the patient will feel the shock and some discomfort. To effectively treat this condition, you should also try to convert the atrial ectopic rhythm. To accomplish this, you can try a couple of different paths. You can use an antiarrhythmic medication, countershock, which would be cardioversion, ablation, or overdrive pacing, which is rarely used. Ablation is a fascinating option. If the patient has a chronic atrial flutter, you can send them to the EPS, or the electrophysiology lab, where they will run catheters and perform the ablation. At the lab, they will cut, reroute, and rewire the electrical activity of the heart, as well as reprogram the heart so the normal conduction pattern is followed. The SA node will once again fire to the AV node and then on to the ventricles. It's too bad they can't reprogram the heart to forget about bad relationships as well.